Everybody, welcome to the second webinar of the EURO-NMD webinar series on FSHD. These webinars are being organized by EURO-NMD in collaboration with ERN-RND and the European Academy of Neurology. And this month, May 2025, is dedicated to FSHD. The webinars are organized together with FSHD Europe and with Professor Nicole Voermans, neurologist and also chair of the FSHD European Trial Network. And we are very pleased to announce today's speaker, Dr. Teresinha Evangelista. She is head of the muscle pathology unit at the Institute of Myology and is also coordinator of the EURO-NMD. And today's webinar is focused on the International Clinical Care Guidelines for FSHD that has recently been updated in collaboration with the FSHD Society, and Teresinha played an important role in this process. So thank you, Teresinha, for being here today, and the floor is yours.
Thank you, Ria. So I will try to present to you as briefly as I can, and it's a very extensive work, the updated standards of care for FSHD. You will have, this is the summary of what will be presented. There will be an overview of how the care considerations were developed. One first part about the diagnostic strategy, and two other parts about the different aspects of FSHD. These guidelines, why should we consider to have guidelines for FSHD? Because the last ones were produced in 2015, were produced and published in the American Academy of Neurology journal, and it was time, because there are new aspects and new treatments that are coming. It was important to review these guidelines. So we based our work on the new aspects that reflect advances in the care of FSHD since the first publication in 2015. But we also took in consideration the work done by the patients. So there are some patient-initiated guidelines that were produced in 2019 and that were based on certain aspects that are very important for the patients, which are like pain, fatigue, mobility, and communication. So this work was started in 2021. As you see, it's a long trajectory between the beginning and now. So in 2021, we established the working group. It had more than 15 experts and from different specialties, and also a very good collaboration with patients with FSHD. Those guidelines are mostly evidence-based and consensus recommendation, but whenever we could, we used the agree-to methodology when possible. And the motors behind this care considerations were the FSHD Society and the EURO-NMD, because both institutions wanted to do a multidisciplinary and international work. So I will start with the diagnostic strategy, and this is probably the easiest bit, especially for the clinics, because you all know about it. I've collected here some images of patients that summarize a little bit what FSHD looks like. There is a different age range for the beginning of the disease, but in what we consider the adult onset, they start from late teens to the early adulthood. Characteristically, there is a left-right asymmetry that can be seen in the first patient, and also in the face of the second patient. And the muscles most affected have to do with the name of the disease. They are the face, the periscapular area, also the distal and proximal lower extremities. Very important are the abdominal muscles and the paraspinal region. The abdominal muscles weakness can be put in evidence through the beaver sign that, as you know, it has a high degree of sensitivity and a good degree of specificity, even if in other diseases we can't see it. As you can see in the video, when I asked the patient to raise the head, there is a upward movement of the abdominal muscles, and this is a positive Beaver sign. So based on this small aspect, on this clinical aspects of the disease, we would also want to know what are the risk factors for the disease severity. And there is a correlation, not 100%, but there is a certain correlation with the D4Z4 repeat size. And we know that patients that have repeat sizes between 1 and 3 units, they are usually more severe. They are the ones that we consider early onset and that have mostly, that have also extramuscular symptoms. Between 4 and 7, we consider it as a moderate severity, and 8 to 10, it's either non-penetrant, they have a mild disease and a later onset, and when we have repeat sizes between 8 and 10, we start to have some complications in terms of genetic diagnostic. What I would like to stress is that even if we consider the D4Z4 repeat size one of the factors for the disease severity, you must be aware that there is a wide intrafamilial variability with the same repeat size, and even a wide interfamilial variability. So this is an important aspect when we are following these patients. When we go for FSHD2, that corresponds to 5% of the patients with FSHD, and that are mostly associated, well, to the known genes for now are SMCHD1, DNMT3B, LREF1, and here also the severity also correlates roughly with the size of the D4 repeat. So we would expect that a combination of a mutation in one of these genes with an FSHD1 size D4Z4 repeat, so what we would call FSHD1 plus 2, will have a more severe phenotype. So an important group of patients are the early onset FSHD patients that correspond to around 10% of all cases, and that for these ones there is good correlation with the disease severity and the size of the D4Z4 repeats. Those are usually in between 1 and 3. However, the relation between the genetics and the age of onset of the disease is still not well delineated. The definition of infantile or early onset FSHD goes back many years, and it hasn't changed. Are patients with the facial weakness that is present before the age of 5, or scapular weakness before the age of 10. And those criteria were established many years ago by George Padberg. This disease, as I said, it's more severe and it's very debilitating. And when we have an early onset FSHD patient, we should and have to look for extramuscular manifestations like hearing loss, retinal vascular disease that you can see in the image on the side. And this is important. It's the Coats disease because if diagnosed, it can be treated. And also these patients have other complications like intellectual disability. There are some children that have a milder phenotype, almost normal muscle strengths, but they complain of endurance problems and pain, even in a case of a normal muscle strength. So for the clinical diagnostic, the group recommended the following. You should consider FSHD in patients with a suspected inherited myopathy, with facial or shoulder weakness or asymmetry of weakness, in particular in the abdominal muscles. If you suspect a patient of having FSHD, genetic testing is recommended to confirm the diagnostic. If you are in the absence of a dominant family history, if you have a physical examination without classic FSHD findings, or if you don't have a genetic confirmation for your patient, you should rule out the FSHD mimics. The other recommendation has to do with extramuscular manifestations in the early onset patients with the D4Z4 repeats in between 1 and 3. And for those, it's mandatory to look for retinal vascular disease, hearing loss, restrictive lung disease because these are the patients more at risk of developing respiratory problems, and also for spine deformities. Moving from the clinical to the genetic diagnostic, I'm not going to talk a lot about the genetic diagnosis. I will try to summarize the recommendations mostly for clinicians, but I would recommend you to go back to the first webinar of this series that was done by the Professor Emiliano Giardini, and that focused mostly on the genetic diagnosis of FSHD. There is also a very good publication from April 2024 about the best practices guidelines on genetic diagnosis for FSHD, and those are an update of the 2012 guidelines, and they were taken in consideration also for the current recommendations we are talking about. So you have you want to do the genetic diagnosis of FSHD in one patient, you have a suspicion. So the step one is to determine the D4Z4 repeat size, and also do the haplotype of chromosomes 4q35 and 10q26. Try to see if you have the deleted allele, the deleted repeat on chromosome 4 or on chromosome 10, and then you need to be aware that there are two common haplotypes on chromosome 4, 4qa and 4qb, and patients with a haplotype that is 4qa develop FSHD. So you need to have, as a criteria for FSHD D1, the D4Z4 repeat size between 1 and 10 units on a 4qa allele. If you have a repeat size in between 8 and 10 units, you need to access the D4Z4 methylation status, because this size is associated also with some cases of FSHD2, and it can be seen in controls, healthy controls, and actually 2% of the healthy of the European controls have this size of D4Z4. If we consider FSHD2, we are usually in alleles, with the alleles identified, or the D4Z4 repeats identified are on 4qa allele, and they range between 8 and 20 units. So if you have this and you want to move forward, you need to assess methylation on the D4Z4 repeat arrays, and there is a specific methylation method that I'm not going to develop, but in fact, if for FSHD1 you only need to know the methylation of 4qa, for FSHD2 you need to measure methylation not only on chromosome 4qa but also 4qb and 10. Once you have a reduction in methylation in this patient, you move on for the sequencing and deletion analysis for the genes associated with FSHD2. You know that the most common is the SMCHD1, the most common of the uncommon. An exception, and I think that Professor Bigiardini developed this more in his talk, is that very low methylation values without a pathogenic variant in one of the FSHD2 genes may be enough for the diagnostic of FSHD2 in the context, in the good clinical context and good clinical family context. So this is like a summary of the diagnostic. So, and at the end you do this and you have, well, you have a negative test or negative tests for FSHD 1 and 2. You go back to your diagnostic algorithm, and definitely you need to exclude other genetic muscular conditions, namely the mimics of FSHD. And also important is that we know more and more that there are uncommon complex FSHD1 alleles, and this should be considered, and there are rearrangement and extended deletions, and so this may need some more in-depth analysis to put the diagnostic. So now you have a diagnostic, and the patient asks you, what is the risk for my children to have the disease? So if the patient has an FSHD1, the risk of inheritance is inferior to 50%. So in reality, this will there is a range of risk associated with the D4Z4 fragments. If you have an FSHD2, the inheritance risk is in between 25 and 50%. And don't forget that it is good practice to consider genetic counseling to all patients and family members, even before testing the patients. If you are testing relatives, you only need to do for the FSHD1 is to identify the D4Z4 in between 1 and 10 in 4QA. If you are testing relatives on a suspicion of FSHD2, you need to confirm the inheritance of the pathogenic variant in one of the genes associated with FSHD2, as well as the presence of a 4QA allele. Because if you have a 4QB, most probably there is no confirmation in this case. And if we go into prenatal testing, it is possible both for FSHD1 and FSHD2 with the condition, the precondition that the relatives or the affected parent has a genetic confirmation of the disease. It can be done at different stages of the pregnancy. The earlier is between 10 and 13 weeks using chorionic villus sampling, or later on between 15 and 17 weeks through the amniocentesis and the analysis of the amniocytes. It's anyhow, it can be difficult, but it's possible. The pre-implantation genetic testing through with in vitro fertilization for FSHD1 is quite complicated because we need to have more than one affected family member so that we can confirm if the oocyte is an affected or non-affected embryo to be implanted. For FSHD2, you need to test for one of the pathogenic variants, and you also need to test the presence of the 4QA allele for the embryo. But all this is very well, I think Enrico give a very detailed explanation of these recommendations. So moving from genetics to what are we going to do with our with individuals affected with FSHD, because they have a lot of functional impairments. So the recommendations are for the assessments that, well, we need to assess these patients regularly, and we need to use comprehensive methods. And the recommendation is to analyze muscle strength, upper limb function, gait analysis, and body composition analysis. For the muscle strength, it is recommended to use standardized protocols, either manual muscle testing or QMT. Most clinics, what we do is MMT. And the muscles that should be targeted are the upper and lower limb muscles, the trunk muscles, and the shoulder muscles. Besides evaluating muscle strength, we should also evaluate the motor function and the muscle endurance so that we have a better idea how the patient is functioning in his daily living. Both the motor function, the muscle strength, and the endurance are very determined, are very affected by the body mass index and the bone health. So these are two of the other assessments that need to be done on a regular basis. So if we move from the assessment to the rehabilitation part of these patients, because we do the assessments and then we want to do good for the patients. Don't forget that in almost all the neuromuscular diseases, the approach for an FSHD patient, and in particular for rehabilitation, is always a multidisciplinary approach. I'm not going to read all the people that should be involved, but don't forget that even if we are dealing with rehabilitation, psychologists and social workers, besides all the other specialties, are needed. And you should encourage your patients to do physical exercise, to move, to have activity, physical activity. And all the activity they do needs to be tailored for their needs, for their capacity. You need to consider the fatigue, the pain, the limitations, and the interventions need to be tailored individually for each patient. There is no one formula suits all. But you have to focus on the upper extremity strengths, the core stability, the lower limb function. Don't forget that facial weakness is extremely impacting in the patient's life. Also, you need to focus on the gait abnormalities, endurance exercises, and fall prevention. So these are the recommendations for the rehabilitation of the patients with FSHD. If we go deeper into the gait and balance, which are two important aspects, to assess gait and balance, try to use timed functional tests. Now it's becoming more current to use wearable sensors and use scales, multi-item or multi-dimensional scales. It is important to monitor the changes in walking speed and the step patterns of these patients. And there is a part that has to do with also with the training or the education of the patient. That is, we need to see what is the role of the compensatory muscles in that patient, and how we can emphasize the role of these muscles and of the compensatory strategies to stabilize the balance and to stabilize the gait. It's important to have targeted exercises to enhance the hip flexor strength and the trunk stability. And you need to consider if the patient needs, for instance, if he has a foot drop, if he needs to have an orthosis to help him with walking. So consider exercise, orthosis, and walking heads to improve the walking stability and balance and to avoid falls. For the upper limb, Access the muscle activation of the key shoulder muscles, so the biceps, trapezius, pectoralis, and serratus anterior. Monitor the activation pattern to guide the functional analysis, because you need to, part of your rehabilitation strategy also needs to be focused on the upper limb function. So the interventions are obviously exercise for scapular stabilization and shoulder girdle strengthening, so that we can improve the movement coordination and also facilitate the compensatory strategies of these patients. Some adaptive strategies may work to enhance function and movement, like taping or bracing, some assistive devices, or even ergonomic adjustments, like in a chair, the chairs or the tables. So there is a need to access the patient in his environment and see what kind of ergonomic adjustments are needed for these patients. The third point in the functional impairments of these patients has to do with lack of thalamus. That is one of the characteristics of the disease, and that is may be we can have very serious problems associated with the lack of thalamus, namely around the cornea. So don't forget to tell your patients to use artificial tears to prevent dryness, to use protective glasses, especially outside, to shield from the wind, from the breeze, but also to shield them from direct sunlight, because it's usually very inconvenient for patients. And during the night, they should use nighttime lubrication ointments to protect during sleep and to prevent nocturnal dryness. And we go now for another aspect, which is the tolerance to exercise. And our patients with FSHD, very often they express that their tolerance to exercise is reduced, that they cannot do as much as other people the same age. So you need to assess this and to see, to identify if really they have an exercise intolerance. You can do that through the VO2 peak, or evaluate the overall exercise capacity through the CPET or a 6-minute walk test. Once you have assessed the patient, you need also to see if to preserve the lean muscle mass. So you should do a nutritional assessment of these patients to see if there is they are overweight, if they have the good BMI, for instance. Then you should promote regular physical activities and establish with your patients some exercise goals for diet, but those exercise goals don't need to be very high. Start slow, and also try for patients to integrate exercise in their lifestyle, in their routine, because it's not only, this is something that needs to be there for the duration of the life of the patient. So we need to integrate it in their daily routine. Most of the exercise that we recommend now is aerobic exercise. There are several types of exercise that can be used, like stationary cycling or swimming or water aerobics. And you can also encourage patients to use personalized tools like BeFit to use as a training guide. And the patients should be, and you should tell the patients that they need to manage fatigue and dyspnea during exercise, because we don't want to have patients that are out of breath or extremely tired at the end of an exercise program. So this means adaptation to the particular patient. So we were talking before about about nutrition, and well, there is nothing very particular in the guidelines. It's what everyone should do: balanced diet with an adequate protein intake, healthy fats, and essential nutrients that should be taken. And this is true not just for FSHD individuals, but for all of us. What should be also discussed with the patients is the potential benefits of calcium and vitamin D. And don't forget that women above the age of 50 and men above the age of 70 are advised to take vitamin D supplements, around 10 micrograms per day. And this is particularly important, not just on FSHD, but also in other neuromuscular diseases. It prevents the risk of fractures and so on. If the patient wants to take some supplements, some vitamins, you should see that case by case, and try to understand what are the individual needs of the patients. So it's not, again, it's not yes or no, they are good or they aren't good. It depends on the patient and of your assessment of their needs. Another important aspect is fatigue and pain. And pain is a very bothersome symptom in FSHD patients. And if we analyze pain in these patients, we need to use a biopsychosocial model. So the primary pain locations are shoulder girdle, legs, and lower back. And obviously there are pathophysiological contributions for that, like muscle weakness or the use of compensatory muscles. But there are also psychosocial factors like psychological stress, depression, and anxiety, reduced social participation. So in this, obviously, these factors will become a vicious circle. So the patients don't move because of psychosocial or pathophysiological contributions, but the fact that they don't move, it further increases the pain and the disuse of the muscles. So we need to cut this vicious cycle to be effective. So don't forget to use a combined assessment tools for pain. There are pain questionnaires and self-reported scales that can be used, like the VAS or the NRS. It's important to map the pain regions and the tender point palpations so that we know where exactly things are not going as they should. Check for the range motion and the functional performance of the segments that are affected by pain. You can use MRI and electromyography and other tests to look for structural and other causes of pain. And you definitely need to do a psychological evaluation, look for depression, anxiety, or catastrophizing scales to apply to these patients to see where we can break the cycle and help the patient. So look for atrophies, contractures. You rule out cervical hernia, radiculopathy, brachial plexus injury, postural compensation that is quite common in our patients. Again, the psychosocial drivers like stress, isolation, or maladaptive coping for these patients. And how do you treat them? So each patient, as I said before, is one individual, and they should have a tailored care plan. And we need to have, again, a multidisciplinary approach to care. But also, and this multidisciplinary approach, well, I would like to say that it also includes the patients and the carers. So you need to empower patients with knowledge about their condition and about the pain management strategies. So educate your patients about lifestyle modifications, assistive devices, self-management techniques, because they are the ones that are living this every single day, and you need to pass them this information so that they can manage themselves better. One way of doing, of tracking the patterns and the responses to treatments is asking the patient to do a pain diary that we will bring to you, and that will you can discuss with him in at the outpatient clinic. And when you want to treat the patient, please prioritize evidence-based approaches. Caution with alternative therapies that are not yet well studied in the management of pain. So some of the approaches are physical therapy, the lifestyle modifications, the assistive devices, and obviously medication treatment. The pain and these patients need a regular follow-up, and they need some support from the exterior. And sometimes the follow-up in our clinics cannot be as regular or as short as it should be. So it's recommended to encourage patients to participate in the support groups with other patients, to have to learn also from their peers. Fatigue, as I said, is very common. There are a couple of validated tools and instruments that can be used in the FSHD populations. I have put it here in blue: the FSHD health index, the checklist individual strengths, and the NRS, or numerical rating scale. All these are good scales to assess fatigue in these patients. And you need to be aware that the fatigue is highly associated with the exercise intolerance, with the muscle mass, and also with the functional abilities of the patient. Obviously, a patient that has a lot of difficulty to walk is going to have to have more fatigue because his functional ability, he is able to do that, but he does that with a lot of effort. So you need to understand what is only fatigue or what is associated with other key aspects of the disease. And to determine the muscle fatigue, you can use the patient's report, the clinical evaluation, the muscle strength assessment, and, as I said, the fatigue intensity scales. And also surface electromyogram can be used, although it's not very currently it's not used very much in our clinics. But this is how we should assess fatigue in patients. So again, you have a patient that is fatigue, you have identified several causes for that fatigue, and obviously, again, you have a multidisciplinary team that needs to tackle the problem. This multidisciplinary is not just neurologists, the physiotherapists, occupational therapists. Don't forget the psychotherapists and teachers and that help with the physical activity, the social workers, and the caregivers, involve the caregivers in the care of these patients. The core interventions are the cognitive behavior therapy. It has been proved that it improves physical activity, it improves sleep, and helps with the social participation. Exercise therapy with tailored regular programs reduces the perception of fatigue. So you should encourage the patients once more to do some exercise. And again, education of the patient and helping them to do their self-management are crucial. So they need to be educated on the strategies they can use to reduce the fatigue. And again, here, a training diary or an app are good ways to for the patient to manage himself regarding his fatigue symptoms. So I'll go to another, and probably I will take a little longer here in the pregnancy, birth, and parents. And I think that one of the most interesting statements in the care considerations is that we should be positive about parenting, about pregnancy, and the ability to be a parent regardless of the limitations. So we should not be we should be encouraging our patients. Two main aspects that are always in the back of the mind of the patients are: how is this going to be, what's going to happen to my muscle weakness, and also what are the problems with my cardiac and pulmonary function. For the progression of muscle weakness, definitely we should have a baseline assessment, in particular about the gait and the trunk strength. So this is the baseline. At baseline you should do that so that we can see what's going to happen during pregnancy. This assessment by physical therapists should also be repeated in the middle of the pregnancy, or if the status of the patient changes during pregnancy. There are no specific timelines or time periods to repeat these assessments, but it means it has to do with the experience of the patient. But at least at baseline they should definitely be done. And the other part is that you should do also an assessment by a physical therapist and an occupational therapist before the patient goes home. And why? Because if lactation is considered by the patient, she may need some ergonomic advices and some modifications to be able to do that as in comfort, so that that is not a burden, an extra burden for the patient, and that she can profit from the interaction with the baby. For the cardiac and pulmonary functions, the cardiac function needs to be evaluated at baseline, and changes should be, you should look for changes during the first and third trimester of pregnancy. For the respiratory functions, also the same criteria. You have to establish a baseline FVC in sitting and supine, and then you need to monitor for changes during the first and third trimester of pregnancy, and also prior to delivery. Some of the important aspects that I think that should be in our heads, because our colleagues are always asking if this is because of the FSHD or not. Do not attribute complications like miscarriage, infertility, or ectopic pregnancy. Do not attribute them automatically to FSHD. There is no proof that this is associated with FSHD, the other way around. And FSHD patients that have one of these problems should go through standard evaluations and care, and not be just discarded as, oh, it's an FSHD, it's related with FSHD. The other thing is that there is no data yet suggesting that patients with FSHD are at increased risk of preterm labor and preterm birth. So if there is a preterm labor or birth, again, this should be assessed as for any other pregnant women. The other thing is, if there are concerns, consider a third trimester ultrasound for fetal size. If you have concerns during the routine pregnancy care, so these patients may have some problems with the fetal size. And going for the delivery, so most important aspects: the mode of the delivery. So vaginal delivery is appropriate for FSHD patients. Okay, like in any other situation, operative delivery or surgery deliveries should be reserved for standard obstetric indications. Okay. However, patients should be informed that due to their condition, they have a potentially higher risk of assisted and or operative delivery. Even if it is not the first choice for these patients, we know that there is an increased risk that they go through a surgical procedure for delivery. We also need to consider that if there is an FVC, a decrease of the FVC, you should always refer these patients to an anesthesia consultation before the delivery. And the other important aspect is there are no contraindications to regional or general anesthesia. Okay. Some patients or some clinicians ask about the risk of hemorrhage. So FSHD does not increase the risk of hemorrhage. However, if the patients have an operative delivery or a cesarean, they need to know that in these procedures there is a potential increase in the blood loss, but FSHD does not increase this risk. In the postpartum, we have we need to be careful about the lungs of the patients. Why? Because either the patient may have a lung disease or there is a truncal muscle weakness. So the respiratory function should be closely monitored in the postpartum period, and be quite free to use the cough assist or the intensive spirometry after a cesarean to reduce the risk of atelectasis in these patients. The other aspect that we sometimes forget is that the patient that goes into labor, especially for the vaginal delivery, don't forget that the patient has muscle weakness and she has problems in her posture. So we need to be aware of it and provide physical support as needed for delivery. So, like for any other pregnant woman, in the postpartum, pelvic floor physiotherapy is recommended. Also, in this case, physical therapy and occupational therapy to get back to the previous functional status. And again, assess the need for assistive devices or adaptive equipment before sending the patient home. And because patients with FSHD may have difficulty coping with the child and the period postpartum, but also because they had a pregnancy and the delivery, we need to monitor closely for postpartum depression. And so it is suggested to reduce the typical postpartum time intervals for checkup of these patients. But women with FSHD also have gynecological problems, and we also need to talk about sexuality, and this obviously needs to be addressed in a one-by-one way. And if needed, we may refer, as we do with other people, to other specialists that may help with any sexuality problems that may occur. And if a patient requires a gynecologic surgery, again, there is no contraindication for the anesthesia, but don't forget that they may require assistance after the surgery to optimize the ambulation, and also don't forget about the respiratory status, because this goes, as we said, for the cesarean. An important aspect is how we manage contraception in patients with FSHD in women. They definitely need to receive a comprehensive counseling, but be aware that they are eligible for hormonal and non-hormonal contraceptives, including emergency contraception. So this is an important readout from this consensus care work. The other aspect that we need to consider is that sometimes if a patient is wheelchair dependent, the menstruation can contribute to skin breakdown, and we need to be careful, and in certain in certain cases, if the woman wishes it, menstrual suppression using hormonal medication may be considered for these patients. So another item in these guidelines is about communication, speech and swallow impairments. There are many new things, but just to recap, we have two kinds of communication impairments. Non-verbal communications through facial expression, as you all know, is impacted, but also the motor speech function can be impacted. So, and we need to discuss this with the patients and with the partners. And obviously, as in other conditions, we need to refer these patients to a speech and language therapist or to occupational and physical therapist, and psychological support may be very important. And the other thing is that sometimes the care teams are not used to these patients, and we should do some training of our care teams so that they are aware of these problems, and that they will clarify their questions with the patients if they don't understand the answer. So, but this is the basic assessment, or the basic actions for speech and language therapy. Swallowing function, the dysphagia is oropharyngeal, is not very frequent. Again, like in any other cases, we should refer for a speech and language therapist for assessment of swallow and for therapy of any signs and symptoms. Cardiac abnormalities, there is much data available, but it's recommended that at baseline we do an ECG, an echocardiogram, and a 24-hour ECG Holter. There's no need for a routine follow-up, except if the patient has cardiac risk factors like any other person. So driven by the patient's symptoms and the cardiac findings at the initial evaluation, we need to then check if we need to do more assessments of these patients. Well, it's recommended to do a monitor regularly FVC and VC, especially in the very severe cases of the disease, but also those with spinal and thoracic deformities. And to better access the patients, adding MIP, MAP, and SNP are very important. Everybody considers that FVC above 50% of predicted indicates a severe respiratory distress, and it requires an urgent action. And in this case, when we have patients with weak respiratory muscles and low vital capacity, consider cough-assisted devices, and then the nocturnal non-invasive ventilation can also be initiated in cases of severe or recurrent episodes of acute respiratory failure. And there are some country-specific recommendations, and this is the first time I put some country-specific. And in in the European countries, FVC inferior to 50%, we usually do a sleep study for nocturnal hypoventilation, and we consider nocturnal NIV if we confirm nocturnal hypoventilation. In the States, FVC below 50%, they discuss immediately the initiation of NIV. Sleep disordered breathing, two types of things can happen: nocturnal hypoventilation or obstructive sleep apnea. Nocturnal hypoventilation, the treatment is non-invasive ventilation. For obstructive sleep apnea, usually is CPAP, but in the context of a neuromuscular disease such as FSHD, instead of a CPAP, the NIV is preferred, especially because of if there is nocturnal hypoventilation. The assessment of these conditions are done by polysomnography to evaluate sleep disordered breathing, and we should associate it to the polysomnography, capnography, or transcutaneous carbon dioxide monitoring. Then, very complicated are the non-respiratory sleep disorders, poor sleep quality and insomnia. They have common causes are nocturnal pain, reduced mobility in sleep, obviously psychosocial factors. The evaluation, well, it's the clinical history, the symptoms profile, and the medication. And there are several screening tools like validated questionnaires, sleep diaries. We can use actigraphy to evaluate the poor sleep quality or the insomnia. If needed, polysomnography, and the two tests MPQ and VAS are good to evaluate the pain influence on the sleep disturbance. To monitor the sleep problem, you can use a VAS, a visual analogic scale, the back depression inventory, or the Epworth sleepiness scale. The treatment, pain management, very important, a good sleep hygiene, treating depression and anxiety, as said before, cognitive behavior therapy, and ergonomic advice, because sometimes just changing the way the patient sleeps may help improving the quality of the sleep. So two other aspects that are now we pass to the associated signs, is the retinal vascular disease. We should screen, so these patients should have an ophthalmic examination at diagnostic, and all children should have annual exams, even in the preschool children age. So while field ophthalmoscopy and OCT are recommended. Why? Because Coats disease is treatable, and these patients need to be directed to a retinal ophthalmologist. Hearing loss, as you know, can be associated, especially with the early disease, early FSHD patients, and they should be screened annually for their hearing capacity. Even if they were screened as a newborn and they had a newborn screening that was normal. And if for older children and adults, we need to ask during the routine visits if they have hearing impairment or not, and if this is something that concerns them, we should again test those patients for the hearing acuity.
Teresinha, we are running out of time.
Okay, so I just go to my last slides. So we also get some recommendations about scapulothoracic fixation, and two methods are recommended, either scapulothoracic arthrodesis or scapular tethering. And don't forget that for scapulothoracic arthrodesis, the patients that benefit the most are the ones with in class 3 with some functional deltoid or shoulder abduction below, with some functional deltoid and shoulder abduction below 90 degrees that improve with the scapular stabilization test. The early onset cases, we should monitor these patients and consider scapular tethering as an alternative for these cases, because it doesn't involve scapular fusion, but just fixation. A word of advice, it's about spinal fusion in ambulatory patients, which is not good practice, and it should be avoided to preserve the compensation mechanisms. So recognize and genetically confirm FSHD, routines, do a screening routine for systemic involvement. Multidisciplinary individualized care is essential, and prepare patients for future therapies and clinical trials. This is the group of people that were involved. And sorry for taking so long, but it was too big.
Thank you very much, Teresinha, for this great overview. I can imagine that these are so many topics that you want to cover that it's a bit too much for one hour. Nicole is also here. If people have a question, you can type it into the chat or raise your hands. I think Elisabeth is also here to have a look at the chat. And I don't know, Nicole, if you have a question, maybe.
Not a question, but just a comment. I think quite often it's mentioned on presentations of sponsors, pharmaceutical companies, they start the introduction with there is no treatment for FSHD, but I think Teresinha has shown that there are many treatments for FSHD, and I think that's what we should make very clear to patients, that there are very many ways in which you can treat the symptoms of FSHD, and that people who are well treated are most likely to benefit mostly from future therapies, which are now being tested in trials. So thank you very, very much, Teresinha, for this presentation, but also for your contribution to the guideline renewal. And I have to go again, sorry.
There is a question from Conrado Angelini in the chat about mental health. Well, I was running out of time, and so I skipped that slide. Not that it is not important, it's very, very important. And I can just tell now that the possible interventions for mental health interventions are the acceptance and commitment therapy, are self-management therapies, and cognitive behavior therapy. And another important aspect is that in children and adolescents with FSHD, we should always look into the family systems, and also to look for if there are other problems like neurodevelopmental disorders or other problems that can impact on the cognitive, on the mental health of the patient. And also, it's important to say that the mental health issues in FSHD are multifactorial, and pain and fatigue are not are some of the main problems. And one of the recommendations that I think that is quite important in the paper is that because these patients have limitations, but to move and to go to outpatient clinic, we probably should start using more of telemedicine and teleconsultations to help with the mental health issues. I've summarized one slide, sorry.
That's okay. I don't see any other questions. Can you see something?
No, there is
Teresinha?
no, that's okay.
No?
No.
Okay. Thank you very much. And next week we have the third webinar on FSHD, focusing on pediatric FSHD with Professor Tracy Willis. So I hope to see you all next week. And thank you, Teresinha. Thank you all the participants. And bye-bye.